Within the 30 minutes it took from him getting to the ER, he got treated. By the time he got to the cath lab and we put the dye in there, the artery had already opened up and lysed. So that right there stopped his heart attack and stopped the damage before he even got to the cath lab. Not everybody is that lucky. Most of the time, it does not open up, and it requires the balloon or a suction catheter to suck the clot out of the artery. So there's multiple teams involved here, multiple people along that line. But it is a very hurried process from the time that a patient enters the door. And with that said, that means symptom recognition by the patient or family member or somebody with the patient to get the patient to the ER in a timely fashion, because that is also a very, very delicate time of which a lot of injury can occur.
Absolutely, and as you mentioned, all those definitely, this whole heart attack treatment is a team effort, and it's not really a one-man or cardiologist shows up and fixes the problem, right. Clearly. But as you just pointed out, the most important aspect of it, most of the delay, studies have also shown that majority of the delay really doesn't happen so much when the patient comes to the emergency room, but happens in this symptom recognition and realizing that it's actually a heart attack at home. Bulk of the time, as I said earlier, bulk of the time they're waiting. It is shown that women are waiting up to 2 to 4 to 5 hours, and they're more stoic and they don't like to complain, and they have never had this before, so they don't know what to think of, and they're thinking either they just queasy, and a lot of times, most commonly we hear, oh well, I thought I was having indigestion.
Right.
Mm-hmm. This is one of the commonest things, and we'll talk about some of the symptom complex, but as Dr. Venkat pointed out, when this whole concept of timely approach to it, when every minute and in those few minutes, and they just came up with this arbitrary number just to standardize and force people to react. And if you cannot react and get to that so-called door to balloon time, by that I mean once the patient hits in the emergency and it's identified as a heart attack by an EKG or some other form of examination, to the time we actually inflate a balloon or inflate pass a wire and establish the flow. That is a key aspect of evaluating an institution's competence in taking care of these heart attack patients. So time and again it's been studied and restudied and restudied. So, but to go back and talk to the patients, if there is one thing I would emphasize, when in doubt, call 911. Right. Just pick up and go, and don't go to the hospital, but just call 911. Because as I also pointed out, bulk of the deaths, close to 50% of the deaths, happen within the first hour, and the most common cause of death is a cardiac arrest. If you think you're having a heart attack, and if you think you somehow can manage to the emergency room, don't do that. Just stay there, call 911. If you have help, get that help. Resist the urge to just drive yourself, because you're on the highway, you're in the middle of traffic, you have a cardiac arrest, and that'll have dire consequences for anybody to rescue you. You'll be harmful to yourself, you'll harm yourself, and you can potentially be in a fatal accident and harm somebody else. So it's absolutely important to understand these simple messages before we dig deeper into this discussion. And I also want to remind our audience, it's a live call-in show, and the numbers are at the bottom of your screen. Please do call in with questions regarding care of heart attacks, as well as any other cardiovascular questions. But coming back to the discussion, Dr. Venkat, now we talk about symptoms and that, and what should patients expect? We are talking about symptoms.
Right.
It's not always crushing pain and they're not sweating and collapsing as you would see in movies. But the symptoms are highly atypical. Can we talk about some of the symptoms?
I think that is the most important part. I mean, recognition of symptoms is the most important key factor in determining who's going to survive and who will do well. Let's just try to make it simple. Let's say a patient who does not have an established coronary artery disease, for somebody who is in their 50s with hypertension, high cholesterol, if they experience chest pain, when I mean chest pain, it's in the left side of the chest. It could be a burning sensation, it could be a heaviness, tightness. Sometimes patients classically describe as somebody sitting on the chest, which could radiate to the left arm, to the left jaw. I think that is a very important symptom, particularly when it's associated with difficulty in breathing, or if they feel that they are not feeling good. I think that is a very important symptom, and they should not wait. They should call the EMS immediately. That's number one. Number two, for patients who have underlying coronary artery disease, when I mean they are known to have blockages and who take nitroglycerin at home, if they get an episode of chest pain, and this pain lasts more than 5 minutes even after taking the first nitroglycerin, that is a sign to call medical help. So they should take the first nitroglycerin, wait for 5 minutes. If the pain does not resolve, call EMS, get the next nitroglycerin, and you need medical help at that point of time. Because we talked about symptom recognition, time is muscle, so that is very important.
I think that's right. I mean, certainly people with who had undergone prior stenting or prior, but they may have some understanding. They likely the patients get smart and are able to distinguish as what is their typical angina pain, or but in a person who's never experienced this is more likely to just be confused with what this is, and if it is a crushing pain, if it's really like a sense of impending doom, or but most often it isn't that. Majority of the times it is not that. So we are always hear these stories, and we were walking out of the hospital just now, and some lady actually walked in and presented to the emergency room, probably much into a heart attack because her blood enzymes were already significantly elevated, but she still had EKG changes. So a cardiologist is operating on her as we speak.
Right. So I think that is a very important part, particularly when it comes to women and patients who are diabetic. They do not have the typical symptoms of classically described chest pain. They may feel belching, not feeling well, like a burning sensation in their chest. Like I told you, when you have that symptoms with difficulty in breathing and it's not getting better, you should call for medical help.
You were saying?
The point I really want to bring out is we as the professionals always talk about chest pain. We ask a patient, you've been having any chest pain? We got to understand to the audience that it's not always pain. It's a symptom of fullness within the chest, sometimes a pressure, sometimes like Dr. Venkat said, a burning sensation. Not every patient gets the exact same type of symptoms, and when we say pain, we're talking about any symptom of the chest, basically from the mid-epigastric, just below the sternum, all the way up to the jaw. Any of those symptoms could be related. Now, what Dr. Venkat described was the classic symptoms that we all look for. That is you don't fool around with that. That is, you call EMS and you get that attended to very quickly, because that is more likely going to be a heart attack in progress than anything else.
Yeah, I mean, those are all, I think when in doubt, I mean, the manifestations can be multiple. You can easily, if those people that have access to computers and other things, you can look up on a website. They'll talk about all kinds of presentations for heart attack, but those that do not have it, those that have time to watch the show, all these symptoms, when in doubt, when it is significant enough, it is much better just to come to an emergency room. Although you might think of the cost and all that, it really doesn't take a whole lot to triage a patient, do an EKG, and rule that out. I mean, well, if you're a 25-year-old, 30-year-old person in good health, or you're running 5 miles a day, odds of you having a heart attack is probably very low. But on the other hand, if you're a 50, 60-year-old person who's not in the greatest shape, or overweight, or diabetic, smoker, high blood pressure, high cholesterol, or has prior heart attacks or prior bypass surgery, all these things incrementally increase the risk of the patient having a heart attack. And I've read and heard that in Europe that they've gotten to the point, and I think even in this country there are efforts being made where paramedics do EKGs, and through cell phones to the latest smartphones and all that, transmit those EKGs to the emergency room physicians, and if they're confirmatory for an acute heart attack, they will then gain that, let's say they're in a place that takes them about 20 minutes to get to the hospital with this patient. So they activate the emergency room physician, they transmit that, and emergency room physician in turn makes the diagnosis and calls out the team. So they're saving 20 minutes of driving time. When we were training, include all of us, we had enough manpower, enough fellows or trainees that would sleep in the hospital. So on drop of a hat, we would just get everything ready. The senior fellows or by the time the senior fellow or the attending cardiologist would come in, we would get everything ready to roll and put the sheets and do all the preliminary preparations. They would come in and because the fastest portion usually is our treatment.
Right.
The triage of the patient, recognition of the problem, getting this patient to the cath lab, and setting up takes really 30-40 minutes of the time. Once it gets out, we get access in the arteries and we put catheters. The treatment time is really a minuscule. Fortunately, most of the time it is the shortest period of helping the patient. So I think the emphasis is really in recognition of the problem by the patient, and then recognition of the problem and activating by the emergency room physician. That is the key in succeeding in treatment of these heart attacks. And it's roughly coming up to midway in this show. We'll take a short break and come back and discuss about the complications of massive heart attacks if they are not treated in a timely manner, and also probably focus a little time on transradial catheterization, which we'll talk about a little bit as to why and what of it. And I also again want to remind our audience it's a live call-in show, and the number is at the bottom of your screen, and please call in with questions pertaining to heart attack treatment or any other cardiovascular questions. We'll take a short break and be right back.
I never thought it would happen to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America. Many occur with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, come see us at any one of our 11 locations. Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
Welcome back to our live call-in show from the heart from Opelousas General here. I'm Dr. Verena. I have with me again Dr. Hammett and Dr. Venkat. All three of us practice interventional cardiology and general cardiology at Opelousas General Hospital. In tonight's discussion, we are talking about importance of timely treatment of heart attacks. In the first half, we kind of talked about recognition of heart attack symptoms and first of all, from a patient's perspective, recognizing it in a speedy manner, understanding the symptoms of heart attack, and getting to an emergency room, and from the physicians and the team perspective, recognizing it as fast as feasible and activating this whole team to initiate the treatment. So, and without getting into the fancy details of these balloon angioplasties or aspirations, first of all, we'll go back, take it a step back, and actually say, what is a heart attack? I think bulk of our patients are sophisticated to understand this, but still, a lot of them have some confusion about heart attack and stroke and what is a heart attack. So maybe you want to go back and talk about what really is a heart attack.
Sure. The heart attack is basically the heart is a muscle that's a pump that squeezes, and it's a cylindrical hollow muscle with the tube. The blood's inside, and the muscle squeezes, and the blood flows in, the blood flows out. I think everybody realizes that. But what a heart attack is, the heart also has its own blood supply. It has arteries feeding it because it as the most active muscle in the body has to have a continuous blood flow of oxygen and nutrients to the muscle to keep the muscle active. And when a heart attack happens, one of those arteries that are feeding the heart muscle itself is blocked, and there's not enough blood flow. It's a supply and demand issue, a balance of the heart needs more oxygen and nutrients to keep functioning, and there's not enough blood flow to deliver that oxygen and nutrients to the muscle itself. And generally what happens, there's a lining inside the artery, and either a cholesterol or fatty plaque tends to build up slowly over time, and that's not actually flow limiting. There's still enough blood flow